When talking about cardiac physiology, we have to be aware that there are two types of cells in the heart. Cells that are found throughout the heart's conduction system. These are called nodal cells. And nodal cells kind of behave like neurons, a little bit. And they are located, if we look at the heart, they are located in this place called the SA node, which I did this SA node where we've got our first section of nodal cells, and then the SA node is going to take that impulse and conduct it to the rest of the conduction system. The next node is called our AV node. That branches out into this AV bundle. Then from the bundle we go down our AV bundle branches, which go down the interventricular septum. From there the conduction system continues up the heart through these fibers called Purkinje fibers. We'll look at those again in a second, but what happens is that in the SA node, these nodal cells will initiate an action potential that's going to spread through the atria and cause atrial depolarization and contraction, and then it'll pause here at the AV node while the atria finish contracting, and then conduct throughout the rest of the system, and will begin depolarizing the heart from the apex, or the ventricles of the heart from the apex up. So those are the first type of cells, and they're behaving a little bit like neurons. The next type of cells are our cardiac muscle cells, and they're going to respond to the action potential from the conduction system by propagating that action potential down the sarcolemma, and it's going to behave very similarly to our skeletal muscle cells. So our muscle contraction is actually happening still as our thick and thin filaments slide past each other, so it's kind of the same mechanism, pretty similar to skeletal muscle cells. But our cardiac muscle cells are different than muscle fibers. They aren't these big long cells as long as the muscle. They're kind of short and they're branched, and they're joined to each other by these intercalated discs. So cardiac muscle cells are slightly different and they behave a little differently. So kind of to start, I wanted to go over a review of membrane potentials and why cells behave the way that they do. And then we can compare that between these two different cells. So if we look at just any old cell, then they've got sodium leak channels that are just always open and allowing sodium to leak into the cell, because sodium is in much higher concentration outside the cell than inside the cell. We've also got potassium leak channels that are allowing potassium to leak outside the cell, and that's because potassium is in much higher concentration inside the cell than out. And then we've got this pump called the sodium-potassium ATPase. And it is going to use ATP to pump these ions against their concentration gradient. So it'll pump out 3 sodium, and it'll pump in 2 potassium. And the differing number of these channels give all cells their different resting membrane potentials. So how the proportion of the channels you have is going to determine what your resting membrane potential is. If we look at the only other ion that's really important in this system is calcium, and calcium is in much higher concentration outside the cell. Unless we look at like the sarcoplasmic reticulum of muscle cells, then it's stored inside the cell, but it's stored in the sarcoplasmic reticulum, which is modified endoplasmic reticulum, and it's not just always floating freely in the cytoplasm on a moment-to-moment basis. So this is going to kind of help give us a foundation for how our different types of cells are responding. So in our nodal cells that are found all throughout the heart's conduction system, those cells sit at a resting membrane potential of -60 millivolts. So that's their resting membrane potential, and they have additional channels that are going to allow them to behave similarly to neurons, not quite the same. So they've got what are called slow voltage-gated sodium channels. And these, when the cell repolarizes, these are going to open up and sodium is slowly going to trickle into the cell. So it'll slowly trickle in. These cells also have fast voltage-gated calcium channels. So that when the cell depolarizes, when this sodium starts trickling in, it's going to hit a threshold that's going to open open these channels. These open at negative 40 millivolts. So they have a threshold of negative 40 millivolts. So sodium slowly starts trickling in and bringing in this positive charge. And as soon as we go from negative 60 to negative 40, these calcium channels open. And this is going to be a difference between these cells and neurons, is that calcium is going to depolarize these cells. So calcium will dump in, so it rushes in and depolarizes the cell. And it goes to its equilibrium potential, which is about 0 millivolts. When that happens, when we get to the 0 millivolts, the calcium channels are going to enter their inactivation state, and then our voltage-gated potassium channels will take back over and repolarize the cell. So that's similar to neurons as well, that we've got these voltage-gated potassium channels, and they're going to repolarize the cell. So if we were to look at this graphically, I'll draw my graph over here. If we were to look at this graphically, then in the nodal cells, they're sitting in a resting membrane potential of negative 60 millivolts. And they've got these slow sodium leak channels. So sodium is slowly going to trickle in and move us away from rest until we hit this negative 40 millivolts. And when that happens, we're going to open those fast voltage-gated calcium channels, and calcium is going to rush in and depolarize the cell. So this first dot here is due to sodium trickling in. Our depolarizing is happening due to calcium rushing out. Calcium rushing in. And that's going to depolarize our cell. And then we repolarize as our voltage-gated calcium channels enter their inactivation state, and our voltage-gated potassium channels take over, and potassium goes back out. So it's kind of similar to neurons, but it's also kind of different. We're depolarizing due to calcium. And we've got these slow channels, these slow sodium channels that are just allowing these cells to generate their own rhythm. These cells are called autorhythmic cells. So they generate their own rhythm, and we don't require any nervous stimulation to generate the heartbeat. So they're autorhythmic, they set their own rhythm, and the reason that they do that is because of this slow voltage-gated sodium channel, allowing sodium to slowly trickle into the cell so that we get this, what's called the pacemaker potential. So this movement from the negative 60 to the negative 40 is the pacemaker potential, and this is what's going to set the pace for contraction of the heart. So then if we were to look at this, then we repolarize, our slow sodium channels open up, we get another pacemaker potential, we hit the threshold, calcium enters the cell, we enter it until we hit that about 0 millivolts, it's equilibrium potential, and potassium is going to rush out and bring us back to rest. When we come back to rest, we open up those slow sodium channels and leak back in until we hit our threshold, and it happens over and over and over again. And our nodal cells set the pace for the heart. Any questions on how nodal cells behave? Okay, so the heart's conduction system, let me grab a model, we might be able to see it on a model. The heart's conduction system are all these nodal cells that are conducting the impulse throughout the atria and ventricle. So the SA node you can't really see it here. The SA node is it's called this, the SA node is our sinoatrial node. So it all starts in the SA node. And it's located at this kind of superior region, maybe that's what 32 is labeling here, this superior region of the right atrium. So it's only found in the right atrium. And this is going to be the pacemaker of the heart. It sets the pace, so, or what's called a sinus rhythm. It's actually a little bit faster than your heart rate. The next node, the AV node, which is kind of inferior to that, down here in between, it's your AV node, your atrioventricular node. So it's kind of in the inferior part of your right atrium before you get to your ventricle. So that's going to be the next place, and it's going to slow our heart rate down. And the reason that that happens is because the fibers there are thinner and they have fewer gap junctions. So all of our cells are joined by those intercalated discs that act as a physical and chemical junction. At the AV node, we have fewer gap junctions. So this is our atrioventricular node. So this is like the second stop. So the impulse will begin in the SA node, and it will depolarize all of the cells in the atria. So we fire an action potential, and it's going to depolarize all of the cells, the cardiac muscle cells in the atria. We'll talk about those and how they behave in just a minute. So that our atria contract, and then the impulse kind of pauses there at the AV node. It slows the heart rate down. If the SA node set the heart rate, it beat about 100 times a minute. So our AV node is going to slow it down some because it's got fewer gap junctions, and thinner fibers. So it slows the impulse a little bit so that our heart's not racing all the time. And then it's going to conduct it down the rest of the system. We can kind of see some of it here. So the next place that the impulse moves to is what's called the AV bundle, or the bundle of His. So AV, atrioventricular, some books call it the bundle of His. And so the impulse is going to go from our AV node to the bundle of His, and then you can see the rest of the conduction system on this model. The bundle is going to branch into left and right bundle branches. So that's the next place, are our bundle branches. Those bundle branches go down our left and right side of that interventricular septum. And if you remember, we've got that cardiac skeleton, that's that connective tissue that's insulating it. So the impulse is being insulated from the cardiocytes all throughout this conduction system that we've talked about so far. So when it gets to that way, when it's passing through here, we're not depolarizing the ventricles down here. Because if you think about it, we have to pump the blood up to get up to these great arteries that are leaving it. So we've got to pump it up the heart. So as this impulse is coming down the heart, it's being electrically insulated by that connective tissue. Then it's going to come down to the end, to the apex of the heart, where we have these things called the Purkinje fibers. And the Purkinje fibers are this network of these nodal cells that go from the apex of the heart back through the myocardium up toward the atria. So they go from the apex toward our atria. So all of the cells in this conductive system behave this way, with this spontaneously depolarizing effect that happens because of our slow voltage gated sodium channels. If we let the AV node, so some people have problems with their SA node, the AV node can set the rhythm. It's slightly slower, about 50 beats a minute. So when you average them out, you wind up having about 75 beats a minute is what's normal. If there are problems with the AV node, then the AV bundle and our Purkinje fibers can set a heart rate, but it's only about 30 beats a minute. It's not really efficient. So you really have to have one of these nodes in control to have enough blood flow to supply all of your tissues. So that's the heart's conduction system. We'll talk a little bit more about it when we talk about the behavior of our heart as it's going through our different phases of the contraction. So any questions on that? So if you look at this figure in your book, it shows it to you. It starts at the SA node. This is what's going to set the pace of the heart. The AV node kind of slows it down. From the AV node, it goes to the AV bundle, and it'll go down our left and right bundle branches. Then our Purkinje fibers, and as the impulse spreads up the Purkinje fibers, it's going to depolarize our myocardiocytes. So our myocardiocytes are the other cells that we have, and they behave kind of like skeletal muscle cells. So they don't have these slow voltage-gated sodium channels. They don't have these fast calcium-gated channels in their plasma membrane, but they do have stored calcium in their sarcoplasmic reticulum that we're going to be able to use to create a plateau. So they have the normal voltage-gated sodium channel that we're used to. So they have a voltage-gated sodium channel, and their resting membrane potential is negative 90 millivolts. So these sit at negative 90 millivolts. And when our nodal cells depolarize and hit that zero from the calcium rushing in, that's going to open these voltage-gated sodium channels. So these open in response to the depolarization from our nodal cells. And then there are normal voltage-gated sodium channels. So they close at sodium's equilibrium potential of positive 30. So now these cells, the cardiac muscle cells, are going to depolarize due to sodium. Our nodal cells are depolarizing due to calcium. These are going to depolarize due to sodium. So sodium rushes in and they depolarize. What this is going to do is it's going to open up these calcium channels in the sarcoplasmic reticulum, and that's going to do two things. It's going to allow sodium to dump out, or calcium to dump out of the sarcoplasmic reticulum and bind with our thin filaments, just like in skeletal muscle, move the troponin-tropomyosin complex off the myosin head binding site on actin. Myosin can reach up now and grab it so that we're sliding our filaments. That's how we're contracting these muscle cells. And what it's going to do is it's actually going to cause a plateau in the action potential. So these stay open a lot longer in these cells than they do in our skeletal muscle cells. And it causes a plateau in the action potential. And we want that to happen so that we can make sure that all of the myocardiocytes fully contract and they squeeze out all their blood. And then they fully relax. And we'll look at this on a graph in just a second what this looks like. So this plateau in the action potential is going to kind of keep it depolarized, keep the cell depolarized longer than our skeletal muscle was depolarized. And then our voltage-gated potassium channels will take over and repolarize the cell. So it's kind of easier to understand if we look at it on the graph. So these cells are sitting at a resting membrane potential of negative 90 millivolts. They are going to depolarize in response to that, the nodal cells depolarizing. That's going to open our voltage-gated sodium channels. So our voltage-gated sodium channels, and we open, and we have this quick depolarization to positive 30, which is the equilibrium potential for sodium. But then we're going to open up these calcium channels that are going to let calcium out into the SR, and it's going to keep the membrane depolarized for a little bit longer. And then we've got this plateau then that you see in the action potential. So this plateau is due to calcium. And it's going to allow the cells to fully contract and fully squeeze out all that blood. And then our voltage-gated potassium channels will take back over, and we'll repolarize the cell. What this does is create a huge absolute refractory period. And we want a really big absolute refractory period because you don't want to stimulate them to contract again before they've had the chance to relax. So if you remember in skeletal muscle cells, we had a pretty short absolute refractory period, so that if you stimulated that cell again quickly, then it could fire another action potential. And what that did is allow you to build up tension, so that we first had tetany, we first had trypae, and then you get incomplete tetany, and then you get those fused tetanic contractions. You need that in skeletal muscle if you're carrying around like 50 pounds. You need to be able to just generate constant force. In the heart, you need to be able to fully relax before you contract again, because if you don't, then you can't fill with blood again. So these cells have to be able to fully relax before they contract again, so that way we can get the blood to come back. If you just had a tetanic contraction and your heart just contracted, then where's the beating? And where's the chance to refill with blood? There isn't one. So this creates this nice long absolute refractory period that will allow the cells to fully contract and then fully relax before they can be stimulated again. Any questions on the way that our myocardiocytes behave? So these cells that behave this way are called, some books call them cardiomyocytes, some call them myocardiocytes. Myo means muscle, cardiac refers to the heart, so there are heart muscular cells. These are the contractile cells of the heart. So they're myocardiocytes or cardiomyocytes. Either way, they're the contractile cells of the heart. This is what makes up most of the heart. So, or most of the myocardium, I should say, is composed of these, with just a few of the nodal cells passing through that conduction system. So this figure in your book compares the absolute refractory period in skeletal muscle cell to cardiac muscle cell, so you can just look at that when you go home and just kind of compare the two. But basically that plateau is creating this nice long absolute refractory period that's going to allow for full relaxation of all the cardiocytes in the atria, and then full relaxation of all the cardiocytes in the ventricles. The only point of electrical connection between the atria and the ventricles is that AV node. They're not connected electrically otherwise, and it kind of makes sense because you want all of your atria to contract and then relax, and then you want all of your ventricles to contract and then relax. And you want it to happen separately so that we can fill with blood. Alright, so the next thing we have to talk about is the cardiac cycle. The cardiac cycle is all of the changes that occur in the heart from one heartbeat to the next. So all of the mechanical changes. So cardiac cycle is all the mechanical changes from one beat to the next. Most books name it this way: the ventricular filling, Isil volumetric contraction, ventricular ejection, Isil volumetric relaxation. Your book breaks it down into what each of the chambers are doing, what phase they are in of either contraction or relaxation. So I'll give you a couple other definitions and then we'll talk about what's going on in the heart. So systole is heart contraction. Diastole is relaxation. So when you have your blood pressure taken and they say, oh, you're 180 over 100, that would be a high blood pressure. But that 180, that first number is your systolic blood pressure, and it's talking specifically about when your ventricles are in systole. So when your ventricles are contracting, how much pressure is on your arteries. And then your diastolic blood pressure is when your ventricles are relaxing, how much pressure is on your arteries. So that's what we're measuring when we're measuring blood pressure. And as far as how your book describes these phases, it starts by talking about atrial systole. So in atrial systole, this is when our atria are contracting. And so if we look at what the chambers are doing, the atria are contracting, and our ventricles are relaxed. And what's happening is since our atria are contracting, the pressure is greater in our atria, and it's going to push the blood through our AV valves. So if we look at what's happening with our valves, the AV valves are open, but your semilunar valves are closed. And actually, before I finish going through this, I want to show you with my hands the cardiac cycle so that you can kind of understand what's happening. And then it helps I think it helps the other words make sense as well. So when a heartbeat happens, first you have your atria contract. Atrial systole is going to push the remaining blood that's in the atria into the ventricles. And then as they relax, your ventricles begin contracting. That's this Isil volumetric contraction, that you're beginning diastole in the atria as you're beginning systole in the ventricles. So then your ventricles fully contract, and that will give us ventricular ejection. And then they're going to relax. And for a minute, during isovolumetric relaxation, all 4 chambers are relaxed. And then this phase is when we have all 4 chambers are still relaxed, and there's passive flow of blood from the atria to the ventricles. So the AV valves are open, and you're kind of passively leaking through to the ventricles, but it's not until we get here that we actively squeeze the rest of the blood in the atria through to the ventricles. So when you look at a heartbeat, this is how it goes. Like, the atria contract, and then as they're relaxing, the ventricles contract, and then all 4 chambers relax. So and when you kind of see it that way, it kind of helps to understand what's going on with these other definitions, because most books use these other definitions. So ventricular filling is happening in 2 parts. Late ventricular diastole, that your book calls it, and during atrial systole. So most books start here in late ventricular diastole, when you're at the end of ventricular relaxation and that blood is passively flowing through our AV valves into the ventricles. Then your atria contract, squeeze the rest of it through, then your ventricles contract, squeeze it out, and then all 4 chambers relax. So if we look at isovolumetric contraction, that's this phase where our atria are entering diastole and our ventricles are beginning systole. So it's kind of like this switching over of what's happening. So your book is calling this phase our early ventricular systole. And what's happening is our atria are relaxing, or they're entering diastole. Your ventricles begin contracting. As our ventricles begin contracting, we're going to, if we start contracting at the apex of the heart, that's where we have those papillary muscles attached to our chordae tendineae and our AV valves. So they're going to snap the AV valves closed, and that's the first heart sound you hear, that lub of the heart sound. So our AV valves close. But the pressure, if we're just starting to contract, the pressure in the ventricles hasn't exceeded the pressure in the arteries, so our semilunar valves are still closed. Now as contraction proceeds, for this next phase, ventricular ejection or late ventricular systole, we're going to finish depolarizing these cells. We'll finish contracting, and now the pressure in the ventricles exceeds the pressure in the arteries. We blow the semilunar valves open and we eject blood. So your book is calling this late ventricular systole. And our ventricles finish contracting, so they're going to fully contract. Our AV valves are still closed, but now we're going to blow open those semilunar valves. So we'll say they open under the pressure of those ventricles contracting. And now blood will be ejected from the ventricles. So after we have full ventricular systole and the ventricles fully contract, in early ventricular diastole, this is like the isovolumetric relaxation, our atria are going to relax, our ventricles are relaxing, and now our pressure is still, the atria are beginning to fill. So in this isovolumetric phase, or relaxation phase, we don't have any of our valves open yet, until we get more blood flowing through for this first part of ventricular filling over here. So in isovolumetric contraction, or relaxation, sorry, this is also known as early ventricular diastole. So if we look, our atria are still in diastole. Our ventricles are beginning to relax. Our AV valves and our semilunar valves are closed. So after our ventricles, or when our ventricles relax, then the blood pressure in the arteries is going to be higher than the pressure in the ventricles. So the blood kind of snaps back, shuts those valves, doesn't go through the valves unless you've got problems with your valves, but that will snap them shut so that our AV valves are closed and our semilunar valves are closed. But we're having slow filling of the atria at this phase, but that pressure hasn't yet exceeded the pressure in the ventricles so that it's not flowing through. And this next part, it's like the first part of ventricular filling, what your book calls late ventricular diastole, is going to be when our AV valves open and blood is passively flowing from the atria to the ventricles. It's not, and that's how 80% of the blood gets to the ventricles, is through this passive flowing in this late ventricular diastole phase. So again, in this phase, our atria are in diastole, our ventricles are in diastole. But now our AV valves are open, and this is allowing for the passive filling of the ventricles. So it's the passive flow of blood from the atria to the ventricles, but our semilunar valves are still closed. And then it repeats over and over and over again. Questions on the cardiac cycle?
When the atria squeezes, does it actually get rid of 100% of the blood that's filled in it?
In the atria, yes. So it'll squeeze out the remaining 20%, and now the ventricles fill. So, but the ventricles don't squeeze out 100% of what they have. So at the end of ventricular filling, if you look at the heart, all of the blood that is left in the ventricles is what we call the End-Systolic Volume. So I'm glad you brought that up, because that brings up these other volumes. So at the end of ventricular diastole, which is when atrial systole is beginning, at the end, at the end of this. So when, after we've squeezed our blood from the atria into the ventricles, but before they start contracting, we call that the EDV, or the End-Systolic Volume. And this is how much blood is in the ventricles at the end of ventricular diastole, so right before they start contracting. So it's the amount of blood in the ventricles prior to systole, or at the end of diastole. so the end-diastolic volume. When our ventricles eject, they squeeze out a lot of blood, but some remains in the ventricles. We call that the end-systolic volume, or the ESV. So this is the blood remaining in the ventricles after ventricular systole. So after they've contracted all that they can, there's still going to be some blood left. If we get a third volume, that's actually going to be important, we're going to talk about in just a second because it's important for cardiac output, that's called the stroke volume. So the difference between your end-diastolic volume and your end-systolic volume is stroke volume. And that's how much blood you're ejecting from each ventricle in a heartbeat. So your stroke volume is how much blood basically you're ejecting per heartbeat. And this is your end-diastolic volume minus your end-systolic volume. And that will tell you the amount of blood pumped from each ventricle in one heartbeat. This is going to be important for what's called cardiac output that we're going to talk about next. So, cardiac output is what we really care about, how much blood we can pump per minute. And cardiac output is specifically referring to how much blood is pumped through a single ventricle in 1 minute. So this is the amount of blood pumped through a single ventricle in 1 minute. Cardiac output can also be calculated as heart rate times stroke volume. And our heart rate then is how many beats per minute we have. So we measure heart rate in beats per minute. And our stroke volume is the amount of blood ejected in one beat. And we typically express that in milliliters per beat. So we have a normal resting cardiac output. Cardiac output that's about 5.25 liters per minute. But you can increase that to meet needs if you're exercising or you're fighting or fleeing or something like that. Highly trained in normal people who just start exercising, they can increase their cardiac output usually 4 or 5 times that. In athletes, they can get up to like 35 liters per minute. But you got to be really well trained. But their hearts become really efficient at pumping, at getting quick and pumping lots of blood. So it's possible to really increase cardiac output with training. So there are different ways that we can affect it. We can change cardiac output. Cardiac output will go up if we have an increase in heart rate, if we have an increase in stroke volume, or if we have an increase in both. So we can increase that, I guess I'll just say we can increase cardiac output by increasing our heart rate or stroke volume. So the last thing that we have to talk about in this chapter is how we're going to do that. How are we going to alter heart rate and how are we going to alter stroke volume? So for altering heart rate is easier than altering stroke volume. So we have what are called positive chronotropic agents. And chrono is referring to time. So we're going to look at stroke volume. Those are inotropic agents, and that's affecting something different. So we're affecting the timing of our heart rate. And positive chronotropic agents are going to increase heart rate. So these increase heart rate. So the sympathetic nervous system acts as a chronotropic factor. So the sympathetic nervous system can actually alter heart rate, but it can also alter force of contraction. So we'll say the sympathetic nervous system will increase heart rate and force of contraction. Epinephrine and norepinephrine are hormones that act as positive chronotropic agents. So they'll increase our heart rate. Other things would be like caffeine, cocaine, methamphetamines, stimulants. So anything that's increasing your heart rate is a positive chronotropic agent. So you could say stimulants. Are we good on positive chronotropic agents? Our negative chronotropic agents are going to decrease heart rate. So these decrease heart rate. This would be things like vagal innervation from the parasympathetic nervous system. So the vagus nerve can specifically inhibit the SA node and the AV node to slow the heart rate. I should step back actually 1 second and say that our sympathetic nervous system is increasing heart rate and force of contraction. It's increasing heart rate at the SA and AV nodes. And we're increasing the force of contraction throughout the myocardium by, when you dump these hormones on, it's going to open up our extra calcium channels. Our sympathetic nervous system is going to be stimulating the release of this. So this keeps our calcium channels open longer. And so if you have your calcium channels open longer, then you've got more opportunity for cross-bridge cycling and harder force of contraction. So the sympathetic nervous system is having an effect at the SA node, the AV node, and throughout the myocardium. Our parasympathetic nervous system is only having an effect at the SA node and the AV node. It doesn't have an effect on our myocardiocytes. So the vagus nerve can inhibit the impulses being generated from those two nodes to kind of help to slow the heart rate. Other things would be like, you've probably heard of beta blockers. That's blocking the receptors for norepinephrine and epinephrine on the heart. That'll help to slow the heart rate. Is that you could block your norepinephrine and epinephrine receptors. And they can do that with drugs. That would be another way. Our beta blockers are negative chronotropic agents. Questions on that? Okay, the next thing that we can do, so this is just kind of a summary slide you've got in your book that tells you what sympathetic innervation is doing. So hopefully you remember from last semester, your medulla oblongata has a cardioacceleratory center. That's going to send nerve pulses along that sympathetic chain ganglia that will result in increasing the rate of contraction at your SA node and AV node. In the parasympathetic division, we have the cardioinhibitory center that's coming also from the medulla oblongata, but it's sending nerve signals along our vagus nerve that will decrease heart rate at our AV node and SA node. Right. So what are ways that we can alter stroke volume? Stroke volume is a little bit harder to alter than heart rate, but it can be done. And so we can do it in one of three ways. First, by altering what's called venous return, the amount of blood that is returned to the heart per unit. So you increase venous return by doing things like exercising. When we talk about our blood vessels, we'll see that the pressure on veins is coming from skeletal muscle contraction. So if you start exercising, then you're going to bring a lot more blood back to the heart because you're squeezing those veins. So the increased venous return is going to increase the stretch on the heart wall, which is called preload, and this is going to, by increasing the stretch, you're going to have greater overlapping of your thick and thin filaments, so you'll get additional cross bridges forming, so you can contract with greater force and increase your stroke volume. So that would be one way to increase it. If you have less venous return, then the opposite would happen, and you'd have a decrease in stroke volume. So venous return is really only something that you're going to be able to alter by altering your level of activity. So that's the first way we can alter stroke volume by increasing the amount of blood returning to the heart, then we can increase the amount of blood that leaves the heart. By decreasing the amount of blood that we return to the heart, we would decrease the amount of blood that leaves the heart. So the inverse is also true. Venous return isn't something that you can really alter on a moment-to-moment basis. Again, it's going to be levels in activity that are going to change venous return. Okay, the next thing that we can do is what are called inotropic agents. So positive inotropic agents increase stroke volume. And negative inotropic agents are going to decrease stroke volume. So an example of a positive inotropic agent would be our substances that are altering myocardium contractility. So a positive agent would be like your sympathetic nervous system stimulating an increase in calcium levels in the sarcoplasm. This is going to result in greater calcium and binding to the troponin and moving it so that we get additional cross bridge formation. So then our ventricles can contract with greater force, so our stroke volume increases. If you've got calcium channel blockers, that would be a negative inotropic agent. Opening potassium channels is not an inotropic agent because that's affecting heart rate, not force of contraction. So the force of contraction is going to be able to increase our stroke volume. If we can contract harder, then we can eject more blood. Questions on that? Then the last way we can alter our stroke volume is by what's called afterload. Afterload is basically how much force the ventricles have to overcome. So it's the resistance in the arteries to the ejection of blood. So if you've got high afterload, then the ventricles have to contract really hard, but there's a lot of pressure, so you're not going to have as much stroke volume. So an example would be what's called atherosclerosis. This is when you get plaques depositing in your arteries, so it's decreasing the diameter. I mean, the diameter is the same, but it's clogged up. So you've blocked off half your artery. Now you've got a lot of pressure that you've got to push past. And it happens as we age. It happens to everybody as we age. And what happens then is they become narrower in diameter, so you've got more resistance to blood flow, and so it's going to decrease your stroke volume. There's not really a way to decrease afterload once you've got like really bad atherosclerosis, unless you're really doing severe like statin therapy, cholesterol therapy. There's actually, alright, so the last thing we're going to talk about today is the EKG or the ECG, the electrocardiogram. You're going to perform these tomorrow. We don't have the best EKG machine, so it leaves a little bit to be desired, but it's kind of fun. So what the EKG is an electrical recording of all of the electrical events that are happening in the heart throughout a heartbeat. So we put these electrodes over 4 different places in your body and then measure the total electrical events, and it gives us different waves that we can see. So different characteristics, things that you should be able to read on an EKG. So this first wave is called a P wave. And it's not a P, and if I were on a test to ask you to label this and tell me what everything corresponds to, and you tell me P, I know this figure says P, but it's actually a P wave. It's not a P, it's a P wave. And the P wave corresponds to the electrical events that are happening during atrial systole. So as the atria are depolarizing, that's causing this P wave. During this PQ segment, the atria are finishing contraction. This next phase, or this next big spike that we see is called the Qrs complex. And the Qrs complex corresponds to ventricular diastole, ventricular systole. But the atria are also relaxing during this time. So you can't see it. It's masked by the massive electrical event of depolarizing the ventricles. So We'll kind of put in parentheses that the atria are entering diastole. You can't see it as its own event. Then we have no electrical events happening as the ventricles finish contracting, so we depolarize them and then our ventricles finish contracting. And then this last wave is the T wave, and the T wave is the electrical events associated with ventricular repolarization or ventricular systole. So our P wave is corresponding to atrial systole or atrial depolarization. Our Qrs complex is what's corresponding to our ventricular systole or ventricular depolarization. And at the time we are depolarizing our ventricles, our atria are repolarizing. And then our T wave is showing us ventricular repolarization as the ventricles enter diastole. And you can, this is a normal EKG reading. So you would have all events, the P wave, and then our Qrs complex, and then our T wave. But we can kind of look at normal and compare it to abnormal and see some different things that happen as a result of changes in the heart. So this is a normal EKG or ECG where we've got our P wave, our Qrs complex, the T wave. And so this is what we call setting a sinus rhythm. That rhythm is set by the sinoatrial node. This next one is what's called the nodal rhythm. This is when you have no SA node activity. So this rhythm is being set by the AV node. So we have our Qrs complex, we have our T wave, but then we don't have a P wave because the SA node is not firing. So our atria aren't depolarizing. So when the AV node fires, we get ventricular depolarization and then ventricular repolarization. And then you've got to wait again for the AV node to fire. This person would be able to live. They're fine. 80% of the blood that's coming into the ventricles is happening passively anyway. They would just be probably pumping less blood than somebody who doesn't have, or than somebody who does have their sinus rhythm, normal sinus rhythm. This is showing what's called a heart block, and this is when you have a kind of an error in communication between the SA node and the AV node. You can see that you've got P waves, but then you're missing a Qrs complex, another P wave, you're missing a Qrs complex, then P wave, Qrs complex, T wave, normal heartbeat there, but you've missed 2 heartbeats. You've skipped 2 heartbeats then in between those heartbeats. Then if we can see this effect if you get premature ventricular contraction, so your atria haven't finished contracting and you don't have that little pause that's allowing them to finish contracting and then begin relaxing. So you can kind of see that as this downward swing. And then this is what's called ventricular fibrillation. This is what happens when you're having like a heart attack. And heart attack can be caused by several things, but this can be in ventricular fibrillation. What's happening is that you're not having really efficient conduction of the impulse anywhere. So your heart's kind of just like jumping all over the place and you're not having efficient pumping of blood. So this is when they would get the your little shock panels and they shock you, and what they're doing is they're stopping your heart for a minute and hoping that it resets the sinus rhythm. So, and that usually works after a couple times. If you're in ventricular fibrillation, then they can shock your heart, it'll stop, and then hopefully reset to normal. So, on the test, for the practical, since you're going to be doing EKGs tomorrow, then I may give you a practical station that's got an abnormal EKG reading, and I would want you to be able to kind of, you don't have to tell me like diagnose anything, but I would want you to say, well, what's wrong with this EKG reading? What do you think could be causing it? So that if you see that you've got these P waves, say, oh, well, then they're not getting that impulse from the SA node to the AV node. So they're not depolarizing their ventricles or something like that. But don't worry, if I'm going to do something like that, I'd give you a normal EKG in your test that you might have to label and tell me what's going on, and then you can compare that normal EKG in your test to the abnormal EKG at the lab practical station. Okay? So this is a great summary picture that kind of shows all of the events and how they all relate. So if we look at these different waves of the EKG and compare them to what's happening in the heart, we see that this P wave is corresponding to our atrial depolarization. So then our atria are going to contract. During that time our ventricles are relaxed. So if we look at what's happening as far as our blood flow, we would be squeezing all of the rest of that blood into our ventricles. The AV valves are open, semilunar valves are closed. This is showing you your pressure changes in your left atrium, left ventricle, and aorta. I'm not horribly worried about you understanding this figure, but if you can understand how all of the rest of these relate, it kind of brings it all together. So then after your P wave, after you depolarize, then those cells are going to repolarize, they'll finish contracting. So your atria are finishing contracting, and then when our ventricles depolarize, they'll begin contracting. Our atria then will begin relaxing. During this Qrs complex, our ventricles begin contracting, and then they're going to repolarize and relax. When the ventricles are contracting, they are, at first, during that Isil volumetric contraction, the AV valves, or the semilunar valves are closed. But then as we enter that late ventricular systole, they are going to blow open because our ventricles the pressure in the ventricles is exceeding the pressure in the arteries, and so blood will be ejected. So you see that blood is leaving the heart during this phase. Then when our T wave happens, our ventricles are now going to relax. Our atria are still in diastole. Our ventricles are going to relax. Now our semilunar valves are going to close. At the beginning, our semilunar valves and our AV valves are closed, but then as we've got that passive filling through the atria, those AV valves will blow open, so you start filling up again.